feel better.
Great. Welcome back to Health Healthcare. We're continuing our mental health testimony today, and we're going to switch and hear from Greta Spotswood, who is the medical director for the Vermont Child Psychiatry Access Program. And we're going to turn it over to you, Greta. Thank you for being here.
Great. Thank you so much for having me. I have a few slides to share today, so I'll go ahead and do that. All right. Thank you so much, representatives, for having me today. I really appreciate the opportunity to talk about our program, the Vermont Child Psychiatry Access Program. So half my time I spend as a child and adolescent psychiatrist supporting the primary care providers working at the community health centers in Burlington, which is an FQHC. And then the other half of my time I spend as the medical director of the Vermont Child Psychiatry Access Program. I'll start with our mission. We really have harnessed collaborative relationships. We could not do what we do without both on-the-ground primary care providers in Vermont and then our state level relationships to inform the work that we do, how we do outreach, who we're partnering with. And our goal is really to get evidence-based strategies in mental health care for kids in Vermont. We want to make sure that kids have access to these strategies in every level, whether it's therapy, higher level of care, what the PCP is talking about, the primary care provider is talking about with the child and their family in the clinic. And so our goal and our aim is to support primary care providers to increase their skills and confidence so that they don't have to make referrals to higher levels of care if those referrals are not needed. And we do this by providing a free and very immediately available service. Any primary care provider in Vermont who serves patients 21 and under can call our psychiatric consultation telephone line and get immediate consultation. So I want to tell you a little bit more about how this works. First, I'll spend just one slide. I don't have to spend any time, I know, talking with this group about the need. So there's a child mental health crisis currently, and I just wanted to highlight that the 2021 Youth Risk Behavior Survey showed that, high levels of mental health need and 14% of high schoolers reporting that they'd made a suicide plan. So we want to be getting care to these children now, and there's really a fire under our service to help the people on the ground provide that care. I'll spend a little bit of time talking about old ways of providing pediatric mental health care because I think it's important context for what we're doing right now. So you can see on the left this group representing the population of primary care patients coming into a clinic. So those are children, those in red have high level mental health needs, and those in pink have some mild to moderate level mental health need. They present to their primary care provider, who we know from national data, primary care providers are most comfortable treating uncomplicated ADHD. I do want to give a shout out to the Vermont primary care providers who've been providing amazing mental health care for their patients for years and years and years. There's a really strong group of those primary care providers who've been doing this work for many years. At the same time, we also know that training really varies in terms of where people are coming out of training programs, and comfort levels really vary. And so nationally, again, we know that primary care providers on the ground are most comfortable treating that uncomplicated ADHD. So what would you do as a primary care provider seeing this patient with a mental health need in front of you? The responsible thing, which is to refer to a specialty clinic. So that's the old way of providing pediatric mental health care. And we know that there are some problems that come up when we stick with this old way. We know that sometimes patients aren't identified as having needs because there's not enough screening happening in primary care clinics. And then once that referral is made over to specialty mental health, we know in Vermont that there are high wait times, as there are across many states. We know that patients sometimes don't get to the mental health clinics because of stigma, cultural or language barriers, social determinants of health. They don't have money for gas. And then our clinics don't talk to each other as maybe they should. We're not set up to talk and communicate with each other, so that a lot of that communication falls on families, and the families are more or less able to do that based on their own resources. So what we know is that this old model does not work. Again, thank you for getting a little bit into the weeds with me here today. It's important, I think, to understand structurally what we're trying to do. So if you look at the light blue, that is the care provided right in primary care by the primary care clinician. If you look at the dark blue bar graph, that's the care provided by the child psychiatry specialty system. So you can imagine over on the left that a child coming in with uncomplicated ADHD will present to their primary care clinician. The primary care clinician will understand, how to assess and treat ADHD. The patient will receive care and continue to receive care completely in their primary care medical home. If you go all the way over to the right, those are children who need more wraparound care. So they might be receiving mental health care through their local designated agency. They might require psychiatric hospitalization at some points, and they might need ongoing child psychiatry care in an outpatient child psychiatry clinic. So our goal is to enable all primary care providers to feel very confident providing the care that they can provide quickly. So they don't have to make those referrals to those higher levels of care. And the highest level of need, so a child with very severe mental health symptoms, is more easily able to access those levels of care, whether it's outpatient child psychiatry, whether it's wraparound family therapy, whether it might even be psychiatric hospitalization at times. And also kind of take kids out of the emergency room. So not everyone gets referred to the emergency room if what we can do is talk through what's going on with the pediatric primary care provider and come up with a plan that can keep kids out of the emergency room unless they really need to be there. So we're saving those higher level services for higher levels of need. And that's really our goal here, working with our partners. We did not invent this system of care in Vermont. We have a lot of companies. So the states in blue have child psychiatry access programs in full swing across the states. Those in aqua have child psychiatry access programs in parts of the state and are working on getting those programs through their whole state. And then those in gray are those without child psychiatry access programs. My last understanding is that 3 of those gray states are working toward getting a child psychiatry access program. So lots of partners for us to learn from, what works, what doesn't work in these programs across the United States. And it's really becoming the standard of care. What does this look like on the ground? So a child might come into their pediatrician. The pediatrician might, say hi, have that relationship with the family, and then something might come up where the pediatrician needs a little bit of help. So they might finish the visit for the day, make a plan to get back to the patient and give us a call. So say it's Dr. Smith who's calling about a 5-year-old Hispanic patient who is adopted with a trauma history, having some challenges at school. Family and teachers are asking about ADHD. Dr. Smith has pretty confident in how to diagnose ADHD, provided screeners, which are called the Vanderbilts, to assess, but really unsure about the results. So in looking at the screeners, it's not straightforward. So Dr. Smith at that point would call us our line and ask about next steps. And we would talk over what's going on, get a little bit more context. And you can see on this flow diagram, you can see that's Dr. Smith at the top calling, seeking advice. They would talk to our liaison coordination team, which are licensed independent clinical social workers who are really able to use their knowledge to triage these questions. So sometimes the provider is just calling, I should say it's really important to call and get just resources for families. Like the provider kind of knows the diagnosis, they know, they feel confident about the treatment plan, but they might need a community therapist. And then the liaison coordination team would utilize our relationships with the therapy community and our understanding about what's going on for that patient in front of the primary care provider. and reach out to all the community therapists to see who would be a good fit and in real time. And so often they're able to provide like 3 therapists who can see that child and take the insurance and have openings to the primary care provider. And that saves the family a lot of headaches calling around. And so that's our goal. Sometimes they end up talking to the child psychiatrist to better talk through what's going on diagnostically, what makes sense in terms of treatment planning. And so then you can see they'll talk to the child psychiatrist, and then sometimes that's it, that's all they need. And then other times the call is bumped back to the liaison coordination team for further resources. We are a small but mighty team. None of these people work for our service full-time, which we actually think of as a benefit because we all have experience on the ground, either supporting primary care providers. In Dr. Budd's case, he is boarded as a pediatrician in addition to a child psychiatrist, so he really gets it. And then I want to highlight Eliza and Andy, who are our University of Vermont team who staff our line on Mondays. And so they really understand it from the outpatient child psychiatry perspective. And then our liaison coordinators, the LICSWs, are folks who have worked in the community as child psychiatry therapists. And we have some other folks who have experience working in schools. So we really bring a lot of experience to this work. So again, stressing that we have quick access, that we are working to keep children with mild to moderate mental health needs in their medical homes and receiving appropriate available care there as fast as possible. Through this method, we hope that folks are not being referred to these wait lists or referred to the emergency room or even the inpatient units quite as frequently. And then children with higher level needs have improved access to those higher levels of care. A little bit of information we've gathered over the last year, the top 5 conditions that providers call in about. So they call in and they say, this is what my question's about. ADHD, that example has come up a few times, but that's not all we talk about. We also see or talk about a lot of anxiety disorders, depressive disorders, impulse control disorders. Those come up a lot at schools. And of course, unfortunately, there's a lot of trauma and stressor related disorders because of experiences children have been through. So that's what providers are calling in about. I wanted to highlight, we were able to look through the free text and find that actually 26% of calls did have a suicidality component. So, we don't provide that type of emergency care. So if the provider calls in and says suicidality is what's happening today, then we kind of help them assess the level of urgency and the need if the child needs to go to the emergency room or have an urgent evaluation. But this is a little bit different. This is when it's not the primary complaint. It may not be something that needs to be addressed in the emergency room, but something that we want to make sure, something as high needs as suicidality, we really want to make sure that that's on the problem list and that we're thinking about what level of care a child needs for suicidality that day. So I wanted to highlight that as an example of how these conversations value add to the understanding of the complexity of these cases and our ability to make sure we're treating all of the needs that are coming in the door for primary care providers. We have, I think it was October, we've answered 648 calls. Sometimes PCPs call about more than one patient. They call multiple times about one patient if they have questions, follow-up questions, things like that. But I also want you to think about the case level or kind of the number of patients seen by each primary care provider and their caseloads. So my understanding is that each primary care provider in Vermont cares for hundreds and sometimes a little bit over 1,000 patients. And so when we're answering the question, we're answering questions both about the patient in front of the primary care provider, but through that education, that information is then available to the hundreds to even over 1,000 patients that primary care provider sees. So we really think about this as an educational service, not just for that one patient in front of the primary care provider that day. As such, we provide a lot of trainings. You can see there at the bottom, we've provided multiple trainings over the last a little bit over a year to hundreds of providers. And this includes mainly primary care providers, but we also want to robustly be supporting the community therapist providers that we're making referrals to a lot. So we want to give back as much as we ask from that community. So for this slide, I wanted to stress that this is correlation. So what we're seeing is what we were hoping to see. So this is correlative, and we can't prove that, it's a causal relationship, but we're really pleased to see that this is at least going in the right direction. So our line started June 2022, and you can see the number of calls, cumulative calls, has increased over time. At the same time, we were able to work with our UVM partners to track the number of patients waiting for care on the wait list at the outpatient child psychiatry department at UVM. And so you can see that number is a little bit over 150 for many, many, many months. And then it starts decreasing. And then you can see the stars are where we provided these very robust trainings through the REACH Institute, which is out of New York, to primary care providers. And the nature of the calls that we get from primary care providers who've been through REACH trainings are really very sophisticated. And so we think those are really good trainings and worth investing in. So we wanted to highlight those trainings. We do many more trainings and work with ECHO partners to make sure we're reaching as many primary care providers as we can. But what we're seeing here is that the wait list at UVM for outpatient child psychiatry is going down. So that tells me that both UVM is doing a good job supporting their primary care team, but also that we're working together to support the primary care providers across Vermont. And so we think that likely contributed to fewer of those referrals being made to UVM because people have other care available for their patients at their fingertips. Sorry, I know folks are talking, but I can't hear very well.
No, we're not. I think it's the
Okay.
hallway, actually.
Oh, gotcha.
So I apologize. It's loud in the building. No,
Okay.
you have our full attention.
As long as I'm not catching or missing something. Okay.
No, you're good.
Lastly, I wanted to highlight the nature of our services. We would not be able to do any of this work without these really strong state level partnerships, collaboration with folks who've been doing pieces of this work for a very, very long time. And I wanted to highlight that the community health centers where I'm housed out of, and I support their primary care providers on the ground in that 50% of my job, really, really stepped up. They understood the need intuitively, being a primary care center. They also know that they're not a statewide organization. And so they've been our fiscal sponsor as we started our program, and we'll be working toward a statewide fiscal sponsor in the near future. And then the University of Vermont Health Network, we're working very closely with VCCYF and trying to see how our efforts can work together even more. Again, they staff our Mondays of our line. And so we're collaborating with them really closely. The Vermont Department of Health and the Vermont Department of Mental Health have been amazing partners, kind of letting us know what else was happening, helping us with the fiscal pieces and the HRSA grant. The Four Pines Fund through the Vermont Community Foundation is our match for our HRSA grant. And so this is a 5-year grant. We just started year 3 of our 5-year funding grant through HRSA, and Four Pines provides match. It's a local philanthropic fund, and we are really appreciative for them because they also have helped us not duplicate efforts across the state, but rather collaborate with those doing similar work. And then VCHIP, I have to give them a huge shout out. They're incredible. We were able to enroll all of the pediatric clinics in Vermont in our program before the year was over. So I think, we started in June, we had everyone for all the pediatricians enrolled by April, which I think is a record in terms of starting these programs. So VCHIP and their relationship with the primary care providers, and they've been supporting primary care providers for years and years and years. So we have a lot to learn from them and continue collaborating with them. So, a little bit more about our HRSA grant, and that's it
Great.
for my slides. Yep.
Thank you, Greta. What a great program. And I know we have a couple questions, Brian.
I have 4 questions.
Mhm.
I'm just going to ask them all at once, and if you don't have the answers, it's okay. I was wondering if you knew, like, in general, what the age ranges were in terms of, like, because you cover a wide range of human development. So, like, I'm just curious, like, how much are, like, sort of children, how much are adolescents, and up to what age would you consider? Because I know, like, developmentally that varies, et cetera. And then the second one is with suicidality, like, how are you assessing it? Are you using, like, CAMS, the Columbia Scale, and then the third one is, you talked about trauma. I'm wondering, like, what you're seeing in terms of violence towards the children, but also, like, anything about any data about homicidality.
Mhm.
And then, and the last one is substance use disorders, like in kids and teenagers, if you're seeing any trends there. And if you don't have answers today, it's okay. Those are things I'm curious about, and it just might be things for us to look at.
Yep.
I asked it all at once so that I would just get it over with. Thanks.
No worries. I wrote it down, so hopefully
I saw. That's why I was like, okay, this is.
So if you reference our impact report, which is hot off the press as of yesterday, I think we sent that out. I
Yes,
hope you
it's on our
have
page.
access
I'll
to
look
that.
at it.
Okay, great. So the age ranges, you'll have more specific data in the impact report, but mainly we're getting questions about teenagers, followed by elementary school age children, followed by 0 to 5, and then 19 to 21. So that's kind of how it breaks down for us, but a lot of questions about teenagers and elementary. Any follow-up questions about age range?
Nope, I think we're good.
Okay.
Oh, sorry, we're not good. Wait, hold on. Art.
Yeah, I have a question. I assume parents are fully involved in the system in terms of referrals and all that goes on here.
Mm-hmm. Sorry, I just want to make sure I understood the question. You said you assume parents are fully involved in the system in terms of referrals?
Well, in terms of, they're the guardian of the children, parents or a guardian.
Yep.
I just want to make sure that I know that they are involved in every step of the way in anything that happens here.
Absolutely. So we can actually answer questions with 0 information specifically about the child. Like sometimes primary care providers call up and just say, hey, I have a question about treating ADHD in like 5 to 7-year-olds. But if it has to do with a referral, the parents are absolutely involved. Yep. And so, yeah, particularly for those 17 and under. So any care provided, the parents are consenting to.
Okay.
And then the second question was suicidality. Yes, so we're using evidence-based recommendations. I think the way that a lot of providers have been trained, myself included, was to think about suicidality in relationship to maybe something that was causing the suicidality, for example, depression or anxiety, and then you might kind of focus on treating the depression or anxiety. But the new evidence shows that we really need to focus on assessing for the severity of suicidality and making sure we're treating the suicidality separately in addition to treating the depression in the long term, so that it essentially buys time and makes sure that that we're preventing deaths by suicide. And so we're really helping the workforce kind of focus on that buying time piece. And we're using the Columbia or the ASQ, really whatever screening measure that's evidence-based and the provider is most comfortable with. And so we're just checking to make sure that that's, recommending that that's being done. And we're finding that providers are really eager to do this type of screening because, they want to prevent bad outcomes for their patients. So that's been a really nice area to work collaboratively with PCPs around. Any questions about that one before I move on?
Just with the way you spoke about that sounded like you're trained in CAMS. Are primary care providers or child psychiatrists getting the same training as other clinicians in Vermont right now with CAMS, which is Collaborative Assessment and Management of Suicidality for everybody who doesn't know that acronym.
Yes, thank you. So the therapy community is being trained in CAMS, but I
Yeah.
don't know of initiatives to train primary care providers in CAMS. I think that I looked at the CAMS program, and all of our licensed independent clinical social workers, our liaison coordinators, are trained in CAMS. But I don't know that that training is as applicable for the primary care providers. But they would certainly want to be referring to a therapist that has that training. So that's where those two might work hand in hand in terms of PCPs being aware of it and knowing that, you know, we're making a confident referral to a therapist that is trained in CAMS. And we do have a list of therapists in Vermont who are trained in CAMS and willing to take patients with a suicidality concern. Great question. And then your next question was about trauma, like in terms of how many calls are about violence toward children. Is that your question?
Yeah, or the children being harmed, like violence in general, like homicidality,
general.
either towards others or being harmed in the, like, just what you're seeing with that.
Yeah, that's a really great question. So suicidality, we were able to run a report using kind of free text. We worked with our IT platform to run that report. We haven't run a report like that for homicidality or violence toward others. We do have that diagnostic category that, you know, might be a proxy for that, but that might be an interesting report to run. I would say homicidality is not nearly as frequent as suicidality in terms of the calls that I've taken. But I think you're right. It's really an important place to turn our attention.
And I'm just curious if we see any changes in it, as we're seeing with other like symptoms or like, it just seems like since the pandemic, there's more acuity, you know, so that's why.
Yep, absolutely. Especially it's coming up in schools and
Yeah.
yep. So that is definitely a place to turn our attention. Substance use disorder isn't one of the primary chief complaints that providers are calling in about, but I would also be interested in running a report on the free text because I think that's often kind of in the background for a lot of the calls for teenagers. So the PCP might call in about with a question about depression or anxiety, and then might mention that, you know, there's a lot of cannabis use. So that again is an interesting question to explore with our IT platform and our free text. So great questions, but yeah, I don't have numbers for you for that.
Thank
Great.
you.
We have 2 more questions and then we're going to move on. Leslie and Daisy.
Thank you, Greta, so much, Dr. Spotswood, for your testimony. It's a great program. 2 questions. Is there an adult equivalent?
Yeah, that's people have asked that question, and when again, we don't have to reinvent everything in Vermont, which is what I love about these programs. So when I'm looking around at other states, there are adult equivalents focused on a specific problem or question or period of risk. So there are often perinatal programs, like in Massachusetts, that it's called MCPAP for moms. There are substance use disorder programs for adults, and there are starting to be some developmental disorder programs for adults. But in terms of the entire adult population, I don't know, I could be wrong, but I don't know of any states that have taken on the entire adult population. It's more focused populations.
So is it worth pursuing these focused ones in Vermont or not yet?
Absolutely. I mean, I think that, you know, perinatal is some low hanging fruit because there are already folks working really hard on supporting primary care providers or OB providers. And there is a perinatal program, but they don't have the liaison coordination team right now. So that's something we're actively talking about. And then I do think, you know, if there were funding and resources to do a program for substance use disorder or developmental disorders, I mean, I think it's a great way to, again, sort through what needs actually need those higher level of care and then how to meet those mild to moderate level needs quickly.
Yeah, it seems like supporting primary care is just a way of keeping people out of emergency rooms, exactly what you're doing. I'm just wanted to ask, is your funding stable?
For the next 2.5 years. Yep, we have the 5-year grant for 2.5 years.
Okay, so then we'll hear back from you and say, what do we do next kind of thing?
I'm sure you'll hear from someone
you.
working on this team.
Well,
Yeah.
we'll hear from someone, whoever is sitting in this seat, we'll hear from someone.
Okay, we got 2.5 years. Thank you.
Daisy?
Thank you so much for taking time to be with us, and I've learned a lot about this program, and we've heard a lot of great things that are happening within it. I'm curious, what are some of the pressure points you can share with us? You've mentioned that you work hard to keep children in their medical homes. Do you have any specific things that you might suggest we could do to help with that, or any other pressure points that providers are facing as they come to you?
Yes, I love your question. Thank you for asking it. So one of our goals in doing this work was to look at where we would like to be making referrals, where we're able to make referrals, and what's missing in terms of those higher levels of care. So I'll tell you one success story, and then I'll tell you like a few pressure points that come to mind. So one success story is that exposure therapy with response prevention is tried and true evidence-based therapy for OCD. We have one therapist in Vermont who is taking a lot of our referrals and took Medicaid and worked with families and used a trauma-informed lens. And it was amazing to be able to make referrals to her. We learned that she was going to retire in the next few years, but she offered to train up other therapists who are interested in learning how to do this type of therapy. And we do make a lot of referrals to her for concerns about OCD. And so we were able to quickly run a training for, I think it was 22 therapists to get the basics of this type of care. And a few of them are talking to us about going on for further training so they would have more robust background. And so it's that type of thing that we want to be catching early instead of saying, oh, shoot, now this provider retired, who do we refer to now? And nobody's taking Medicaid. So when you talk about pressure points, that's one that comes to mind as a success story where we were able to catch that need early. There are other pressure points. I would say overall higher levels of care remain harder to access. And again, I don't think that's a surprise. In terms of when a child does need trauma-informed care in an emergency room. I know some of our state partners have been working on that and supporting emergency room providers to be trauma-informed. But then, when a child really does need psychiatric hospitalization, which we try to avoid if possible, to have that psychiatric hospitalization be available and excellent, and then have great communication back to primary care providers. So those are some initiatives we're talking to the state level partners about. Other pressure points, I think state level partners are also thinking about how to better support emerging psychosis in kind of older adolescent populations. And so what we're doing right now, again, we're a little after our first year, but what we're doing right now is trying to refine the way we collect data so that we have specific numbers behind where would we have liked, what's kind of the ideal referral versus what was available. So we'll have better data for you for that question in the next few years, but those are a few that come to mind. Substance use disorders in adolescence is another pressure point.
Would you combine 3 and 4, the first episode psychosis and substance use disorders? Are those related? Or are you looking at?
For some patients, they're very much related. And for other patients, they just have a really strong family history of psychosis. Again, we don't want to be overdiagnosing. These are children that I come across maybe once a year. So we don't want to overdiagnose things like early psychosis. But there is evidence in terms of how to support those children for the best outcomes. And I think we'll continue working with our state partners to make that care available in Vermont.
Got it. Thank you.
Mm-hmm.
I really appreciate all the data, Greta, that you all are collecting on this. I just breezed through the impact report. I encourage everyone to read it. It's really informative. So thank you. And we look forward to hearing much, much more. And thank everyone who's doing this within the organization. We appreciate it. Oh, sorry, wait, one more question.
Yeah, Greta, I'm wondering what your email address is. Would it be Spotwood?
Great question. I didn't put that on there. I apologize. So my Vermont Child Psychiatry Access Program email is M, as in Margaret, M Spotswood, SPOTTSWOOD @VTCPAP.com.
BTC what?
CPAP, VTCPAP.com.
And Claire has it too, so we can get it to you.
Okay, got it. Thanks.
Great, thank you so much, Greta. We appreciate your time.
Thanks so much, representatives.
All right, we're gonna go back to.
That's it.
Take a little tip.
I'll just need to read.
That's fine. Actually, Alex, we have a question while Emily's logging in.
Since we just finished up with 988, I'm gonna ask you my annual question. How's 2023 looking for suicides?
So it is looking better than 2021, which was that really terrible year, but more on par with 2022, which was around 120. So we are still, that old line that was trending about 33% increase.
Yeah.
We're now back to that 33% increase.
How many do we have pending still, do you know?
Oh, yeah.
Can I ask a follow-up question from Dr. Spotswood?
Can we wait till we're done with this?
Well, it's to them.
She left.
No, it's
Yeah, but aren't you, do you have a follow-up question that you're
No.
waiting on? Oh, okay, yes, go ahead.
So I
Sorry.
was just wondering if there's any interest in an adult program, the perinatal, where the energy would come to think about that.
Yeah, that's what
I wasn't fully paying attention to the testimony. Do you mind a little?
I don't want to
explanation?
spend time,
Yeah,
yeah.
can we take that offline?
Totally.
That'd be great. Emma, you have your hand up?
I do. Good morning. I was hoping to also address that question because I do think there are some initiatives that DMH has funded with other nonprofit partners that kind of look similar to an adult telepsychiatry project, and I can elaborate a little bit on those during my testimony.
Okay, great, thank you. So, and I just want to bring, sorry. I want to reset the next 35 minutes. So I think what I would like to do is have you all continue and look at the DASSA vacancy numbers and look at the peer support if we have time. And then switch over to Voz. And then I've already coordinated with Nicole for time tomorrow for what we don't finish. Because I have a feeling peer support and CCBHCs are going to have a lot of questions. We want to make sure that we hear from Voz. So that's the plan. So let's do DASSA, see where we are, and we'll.
Okay, so I'll just jump in around DASSA vacancy numbers, and certainly Vermont Care Partners would be a good resource for any future taking any questions, but in the latest report. So the overall, you can see for vacancy numbers, there's been thankfully trending in the right direction, but still quite high. Kind of how I would summarize that. And then, so that number you'll see there is around 928 for the community-based system of DASSAs for vacancies.
Is there a denominator or percent?
Let's see. Not on this slide. They do have a breakdown in their overall around how much that is mental health versus DS.
And we will be hearing from Vermont Care Partners. We don't have them scheduled yet, but we can dive into those.
Show the slide of the investments made. So there's an employee investment program, and a new general fund appropriation of $3 million that grosses up to $6.9 million. So approximately 500 staff received a total of $1.5 million. in forgivable loans, and then 96% of employees who received tuition assistance fulfilled their commitment to stay on, so were retained. So I think that's the good news, is there's a lot of appreciation for those staff who are already there, who are getting loan forgiveness, and that's a retention tool that's been successful. So that's a 20% increase over previous retention rates. There was a period of time where we threw a lot of things at the wall and people were still in such flux that we didn't quite have a handle to hold on to staff.
And so have all the retention funds been given out?
No, so there's a current new funding opportunity that is moving through Vermont Care Partners now. So there was additional funding that was through ARPA. I'm going to double check that to make sure, but no, there's still funds going to go out of Vermont Care Partners.
And so Amy, if that can just be on your list to bring back to us, that would be great. Okay. So trending down, but still a real need for community-based staff to help our system of care. Yeah. Any questions on that?
Do you mind if I add just a little? One of the more challenging positions is overnight staffing positions, those nocturnal shifts. And so, when we think about our system of care and back to the, closed beds or the pyramid of different levels, from a mental health crisis bed perspective, the vacancies that end up in your overnight shifts impact that ability to, or can impact the ability to fill those resources. So we see it as a positive that is coming down. And we also, need to figure out a way to encourage folks to work the overnight shift, which isn't for everyone. It would not be for me. I fall asleep at 8 o'clock. So, but it is a really challenging shift to fill if folks are also managing their daily lives. So, we have some, we certainly have some work to do with that group of open and vacant positions.
All right.
Yeah, and Lori, it has to do with your question way earlier here about being able to work in other facilities. Is there do you think that the union contracts could be structured in a way that allows it to get any folks that they might be willing to give on an issue like that to, I actually think it would secure the future a little bit if they were able to, if they were working in multiple facilities. Is there any? It's been approached.
Sure. I'll never speak on behalf of a union.
Right.
I will say, though, in my experience, folks want to work in safe, well-staffed facilities and resources. And so I always think it's worth the conversation, whoever that's with, between union leaders and the state or the individual entities, because we want to make sure that we're looking at every option possible to staff. And so I think that, we're open to those conversations, and I assume other resources are as well. Yeah.
But, and DMH, does DMH have those conversations, or is that done
It happens through negotiation.
between DMH or with agency of, who's responsible within the state agency?
For state of Vermont staff, those conversations happen between the state of Vermont Labor Relations Team and VSEA. And DMH staff are a part of the broader collective bargaining agreement. And so part of those conversations include how that impacts other positions within, say, the Agency of Transportation. Whereas a medical center like UVM Medical Center, or Howard Center, they're a unionized workforce as well. And their workforce, that union is specific to the work that those entities do. But from a state of Vermont perspective, that happens between our team at Labor Relations and VSE.
just a point about this as it's come up a couple times. I'm also concerned about how that might impact the folks who are getting care in those places. Some of them see those providers on a semi-regular basis, I'm guessing. And those providers are people that they have developed trust with and relationships, and that directly impacts their ability to become healthy. And so that could disrupt their, ability to.
But I could see it being something where, I mean, it would, just from my little world of thinking about it, be more of a long-term thing. It wouldn't be like day to day. I mean, if there was a slowdown or a time at one place where someone could go for 3 months to another place, it's just a thought. The field.
Well, and it's way out of our bailiwick in this community.
Yeah,
But it's really good information for us to think about and potentially talk with
Worth
people.
thinking about, right?
And there are folks who say work for Washington County who work also at VPCH as a substitute or a temporary worker from that perspective.
Yeah.
That's not sharing staff, but there are a certain number of skilled professionals in the state. And it's not uncommon for somebody to hold a job at one agency and maybe cover emergency services at another agency so that does happen at the will of the individual who may want to do that.
Right,
Yeah.
right. And there may be some disciplines where you don't want to do it at all, and
Sure.
others where it makes sense. Whatever.
All right, why don't we do peer support quickly, and then we'll move to BOSS.
Okay, so the committee's likely familiar with the Peer Workforce Development Initiative. There was a grant developed by the Department of Mental Health to help the state build and maintain this infrastructure, which we did not have. And that is to develop a mental health care workforce. And so where we are now, there's been a sort of 3 phases of this, and we're in the 3rd phase. And so the first phase, there's a stakeholder group that's been informing this process. And so that report was released in February 2023. So if you have questions about kind of where we've gone up until now, that's a good place to look. But it really brought up some consensus around what are our recommendations for developing and implementing this program. Because we haven't had a peer certification program. It's a reminder that means that you can bill Medicaid for peer services. So it hasn't been an approved Medicaid service in our state. And so where we're at with phase 3 now is the bullets that are listed here. And so there's a lot of details. We're working with our partners at OPR as well, because that certification needs to have oversight. And so we need a process for how to certify those, for how to handle folks who are already serving as peer support specialists. And then the credentialing, the test for it, how that's going to work, how that's going to be overseen. Also, what are the education requirements? And, there's a big conversation in Vermont around, we want to be integrated, but there's, recovery peer coaches, and then there's intentional peer support for mental health. And how do we want to distinguish? Some folks may want to be interested in getting certified and trained and having both specialties. So those are things that we're looking into. And then I think the only other piece would be, they'll be advising on the drafting of a request for proposals for an entity to oversee the screening and training of the staff. So that's kind of where we are at this point. All the meetings are posted on our website. And so it's a good place to kind of check in and see kind of how the conversation's going.
And we will be, this is the point person on this work for this committee. This has been a focus of this committee as well. And so we are going to continue seeing it through, and we will be working on a committee bill to be able to provide the legislation needed to move forward with the certification. So we'll dive much more into this in a couple of weeks. But are there any questions right now? Great, thank you. This has been extremely informative, and we really appreciate all the work at DMH and with all your partners to, get these programs up and running and ensure that, Vermonters can get the care that they need. So we look forward to the conversation tomorrow with whoever's coming back for CCBHC. Sorry, we couldn't fit it all in, but you know how we are. We have a lot of questions. Anything else you want to say?
No, we appreciate the opportunity to come and talk about the things that we're doing and also where we have some opportunities for improvement. So thank you. We appreciate it.
Great, thank you. Yeah, I'm sorry.
I want to acknowledge like how much progress you're making. Because this is my 8th year on the committee and like, and our system of care has struggled so much, but it's really like, it's just really nice to see how hard you're working and the progress. Like, I want to just acknowledge it. It's clear, like there's like clear changes happening that are for the good. So thank you.
So can I also add that I love your slides. They're very clear, accessible, saying what Brian is saying. So thank you for that.
Yes, thank you.
Especially your pyramid.
The pyramid.
All right, let's move on to Emma Harrigan from Vaz, who's been waiting patiently. Thank you, Emma. Thanks for joining us.
No problem. Happy to be here virtually. I'm sorry I couldn't be in the committee room today.
No worries.
Wait for folks.
Just to
Okay.
Look to see Emma. I get 100 emails. I've never.
Oh, you've never seen Emma?
Oh, well.
I save all your stuff, Emma. I save it all.
Well, I'll have to make a trip. So good morning, everyone. Hi, my name is Emma Harrigan. I am the Vice President of Policy for the Vermont Association of Hospitals and Health Systems, also known as VAHS. I think this is my first time testifying in front of this committee this biennium. So I see some new faces and some familiar ones, but it's nice to meet you all. I was planning to cover a discussion of what our wait times look like currently in emergency departments. Talk a little bit about our plans to upgrade our emergency department data collection, and then touch upon a few programs that are affiliated with DMH or supported by DMH funding, but not necessarily affiliated with designated agencies or the traditional system of care that we also think are really important and contributing to, the success we're seeing. I think Representative Chena beat me to one of my opening comments is that, I've been also working, with this system for a long time. And I think, we are nowhere near the levels of crisis we have been in the past. We've definitely seen improvement over the past several years, and it is really encouraging to see the change happening. There's still a long way to go, but it's still positive to see that. So I'll start with our wait times. So just as a refresher, and it's in the reports that we send you every week, VAHS collects point-in-time data from emergency departments on Monday and Thursday mornings for patients who are waiting for mental health placement. This is for patients regardless of their legal status, which is something that's different from DMH. So if someone's there voluntarily or under the custody of the commissioner, we get their information. We get it regardless of who is the insurance or the payer. So we have Medicaid and non-Medicaid individuals reported to us. And we also asked our emergency department to categorize what the individual is waiting for. So we do get information on people who are boarding for inpatient care, but there's also occasionally people boarding in emergency departments, waiting for crisis bed or residential placement or a reassessment by a designated agency. And we also get that information. So we've definitely seen some improvement from our 2021, 2022 numbers, but we still have about 15 to 25 people on any given morning who are waiting for that next level of care. Wait times have definitely improved. We have been very close to about 50% of patients on any given day having waited less than 24 hours as of that report for care, which is better than we've been. Typically, when we first started measuring, it was very much the minority of patients had been there less than 24 hours. I do want to say that we are still seeing 1 or 2 people each day who are waiting hundreds of hours for placement. And by hundreds, I mean anywhere from like 120 to 150 hours, so about a week. When we do see patients who are waiting, and this is more anecdotal, sometimes it can be geriatric patients, so older patients with complex needs. Sometimes it can be patients who have substance use challenges or neurodevelopmental disorders. So complexity definitely contributes to whether someone waits a little bit longer. In the past couple months, we have seen, wait times for adolescents can ebb and flow with the school year, with high pressure points of the year like holidays or summer vacation. When there's transition in adolescents' lives, we tend to see some ebbs and flows in requests for inpatient care. And I believe there's been some recent transitions of bed locations at Brattleboro Retreat to optimize efficiency, which took a few beds offline. I believe in the past couple months, those beds have since come back online, and we've seen an improvement in kids' wait times. But we see a lot of variability with adolescents. I do want to make the point that 24 hours, when I use that 24-hour metric, 24 hours is our starting point. It's not our goal. We definitely want people waiting closer to 4 to 8 hours in emergency departments versus 24 hours or days. I think we still have some work to get there, but our ideal goal should be 4 hours. When we see people move through emergency department at 4 hours on average or less, it just results in better outcomes for everyone coming in through the ED. It reduces injury, it reduces risk for patients. So that's our goal. But I do think we've made progress getting to that 24-hour mark. We just still have a ways to go. I did want to just comment that, and I think Commissioner Hawes and the DMH team covered this morning, flow is definitely multifaceted. And bed availability for inpatient care is an important component of that. And I think we've seen that we've had more beds available for inpatient care in the past several weeks than we have, frankly, ever had since Tropical Storm Irene. But we still need to have the right beds for the right patient. And that there's other things that we've been working on in emergency departments to improve flow, like implementing a statewide medical clearance process between psychiatric units and emergency departments so that people aren't getting unnecessary tests that are creating delays in their placement and inpatient. We've really stepped up our coordination with DMH for folks who are in the custody of the commissioner. Transportation is a huge component. And I think one that we still struggle with in Vermont, and I know EMS and others have also been highlighting that this year. We are heavily reliant on interfacility transfer for psychiatric patients. And with all the challenges we've been seeing with that, I think that also contributes to wait times in emergency departments. And then the step down availability, like the residential facility and the opening of the secure residential, those all make differences. So I would say that bed availability on the inpatient side is critical to improving boarding in emergency departments, but there are many facets of improving our system of care that will also contribute to those numbers and those wait times looking better. And I'll pause there if there's any questions.
Good information. Topper?
Yes, we heard earlier that there were vacant beds.
Mm-hmm.
So I'm wondering what kind of beds are not accessible?
I don't think I have a good answer to the specifics of that question, but I really want to dive in with DMH on that. I will say what we hear from our clinical leaders in hospitals is that the ideal number for occupancy for medical surgical beds is 85%. And I would say at least up to from Tropical Storm Irene up through COVID, occupancy in level 1 beds, for example, in the state had run at 99%. And so very little room for flow and transition. And we were also seeing similar high occupancy numbers for other beds in the system, voluntary beds and regular involuntary beds were running at 92 to 95%. So we do expect to see some open beds. I've yet to look and see whether, like, are we running at 80 or 90% occupancy overall in our system? So we do need beds available for flow. But we also need to do the work to see whether we have the right types of beds. So do we still need 47 some level 1 beds? Do we need to look more at needs for geriatric, for example, or for adolescents, or for just general voluntary, or forensics? I know forensic is a big conversation that's coming up too. So I think that work still needs to be done, but I think that's the next step in our question is, do we have enough beds and do we have the right types of beds?
Okay, thank you.
Any other questions? on this?
Mm.
Art?
This question may be for you, Lori, more than anyone. The legislation last year that tightened up, I'm aiming at the violence in the,
Yes.
did that go into effect yet? Has
Yes.
that taken effect? And I wondered if,
Yeah, I'm sure Emma can, the healthcare workforce violence, I forget what the act was.
Mhm.
Emma, did you have a specific question, Art, or just?
well, I just wondered if it's gone into effect, whether you've seen any difference in the emergency rooms or hearing anything about it from that standpoint.
So it has gone to an effect. VAS has been working with the Department of Public Safety to create a model policy, but that law enforcement can use that will help kind of guide the process for when law enforcement are called into a healthcare facility when a healthcare worker has been assaulted. And we're working through something called the Law Enforcement Advisory Board to get that approved. Since May of last year, we have been collecting numbers on the frequency in which healthcare providers and hospitals have called law enforcement for support. I don't have those numbers off the top of my head, but we can give an update to the committee. And then I believe the law also contracted or required the Vermont Program for Quality in Healthcare to do some work with hospitals to examine what hospitals need to prevent violence in facilities, what kind of training and support. And I think we can also make sure that that's available to the committee as well. So we've seen some use of the law, and I see my colleague Devin in the back with her hand up.
And I will, and Devin, before you start, I will say, I just sent everyone that report last night. I believe it was, that report she's talking about. Go ahead, Devin.
Yeah, Devin Green from Buzz, and I will just say qualitatively speaking, when we meet with our healthcare leaders, they say that there has been a difference. Just in the fact that it's been acknowledged and that people understand that they can call law enforcement in these situations has made a huge difference to them.
Okay. If there's
It's
more-
not solving the problem, but
Okay.
it helps.
I was just gonna say, if there's more to do, you should be made aware of it. Thank you.
Great. Brian?
So I heard you say that you've begun tracking calls to law enforcement related to violence towards staff, or I guess violence in general, because if it was violence towards another patient, they'd probably also call. So like, violence in emergency room settings. Is there any other way that we're tracking the violence? Because if providers are hesitant to call or calling only at a last resort, like, is there any other way we're tracking violence? Because the problem may be bigger than the calls, that's one question. And then I heard you answer some of my other questions. So about the training piece, but like you mentioned that, and I'll read the report. So I'm not going to ask you those questions until I read the report. But so maybe I shouldn't ask this one, but I'm going to, which is just because this particular piece, I think is really important. Has there been any discussion about, like, as we embed peers into the system of care, the role that peers might be played in conflict resolution and de-escalation in the emergency rooms versus police response,
Yes. So your
Yeah.
first question regarding calls, I think, is one that you'll find some discussion in the report from VPQ, because there's a standard in law, right, that we've enacted where law enforcement can be called, but there's other incidents that can happen in hospitals and healthcare facilities that don't meet that standard, but still create an environment that is uncomfortable or dangerous for healthcare workers that may not be collected in our data. And the VPQ report does talk a little bit about opportunities for standardization. And I'm sorry, can you repeat your second question? I've lost it already.
It's okay. Just in terms of like the trend in the system of care to embed. Can you hear me okay? Because I have
Yes,
this
I
mask
can.
that I feel like I'm muzzled.
You're all good.
Okay, like that in the system of care, as we have this trend to embedding peers, has there been talk about the role of peers in just de-escalation and conflict resolution in the emergency room settings? almost like a prevention measure, like if things are getting heated, is there a way, because, and I say this just because often when security is called or the cops are called, that escalates. You have people who use force coming in. So whereas I see like nurses and other providers like social workers, et cetera, trying to de-escalate. But I mean, peers have a special connection with others. And if there's a patient, I know family members are another story, or spouses, abusive spouses, things like that. It's another story. But like if patients are escalated, just is there work being done looking at the use of peers to help kind of like reduce violence in emergency rooms?
I don't know of any work specifically on peers, but I do think it is a huge opportunity. So I agree with you. It should be included for sure.
You can't see it, but Devin raised their hand.
I can't see it either, so thank you. Devin, do you want to come up?
Sure. I think when we talked about certification of peers and bringing peers into hospitals more broadly initially, like a couple years ago, this was one of the things that we talked about as a benefit to having peers. And I think as soon as we, analogized it to the role of substance use disorder counselors and those folks, people latched onto it right away. They saw the usefulness of it. I think we're still trying to figure out, I'm not sure if the certification process has happened, but we want to incorporate peers and once they can get paid and everything else. One thing we'll have to be careful about are conditions of participation for hospitals, which are the requirements there for, anyway, I think peers are a good thing. I'm not going to get into, and I think you're exactly right. They're good for de-escalation, and we'll want to figure out a good way to incorporate them to the fullest extent we can.
Your certification has not happened yet. We'll be working on legislation for that.
Yeah, I didn't think it had, but I just wanted to make sure. But yes, we are very supportive of peer certification and also for them to get reimbursed. We think that they'd be very helpful in our emergency departments and elsewhere in hospitals.
Thanks. I think that underscores the importance of us doing that work this year.
Yeah, definitely. We need to get it done.
Yeah. Thank you.
Thanks. Thank you. All right, Emma, back to you.
All right. So our emergency department wait times data upgrade, and I know Representative Houghton and I have been in touch with this over many months. So VAWS has a data use agreement with the Department of Health and the Department of Mental Health to use something called syndromic surveillance data to report on volumes and wait times for people in emergency departments with mental health conditions. Syndromic surveillance is something, it's a CDC product, Centers for Disease and Control, and it's meant to be used to track the prevalence of disease. So how it's been used traditionally, for example, is measuring the prevalence of tick-borne illness or respiratory, or I'm blanking on another example, but so for example, during COVID, CDC syndromic surveillance was used quite extensively to track the prevalence of respiratory and COVID-related illness coming in through emergency departments to help us kind of predict where we might be in terms of a surge. So what we're doing with our partnership with VDH and DMH is we are trying to see whether we can use that data to measure emergency department volumes and wait times for mental health, which hasn't really been done yet. So we're kind of still developing our expertise, and we're working with emergency departments to validate the numbers we have to make sure that we're accurately capturing what volumes they're seeing and their associated wait times. So we are looking, for example, at chief complaint that comes in through the emergency department for specific words that may be related to mental health conditions. To pull in a subset of those visits, and then working to identify their admission and their departure date from emergency departments to measure wait time. So we're closer than we've ever been, but we still have a ways to go. But I will say that the Department of Health and Mental Health have been great partners in this work and see a lot of utility in this effort. Some of the programs that were discussed this morning that are looking to reduce emergency department utilization for mental health, this would be a great way for this data to support those programs. I made notes on, for example, where the psychiatric urgent cares have popped up across the state. So we could definitely use this data to explore more than just people who are boarding in emergency departments for mental health, which is what we would need to replace our current measure, but also looking at just larger population volumes of people seeking those services, whether they're boarding or not. So that work continues. I am hoping to have something in the coming months to share with the committee, but it's taking longer than expected for us to build our expertise.
No, I think it's going to be great, though. I mean, I think it will provide us so much more data to fully understand how the policies and programs that are being put into place are helping Vermonters and the effects it's having on the emergency room. So I really look forward to that. And I appreciate you continuing to spearhead that and work with the partners.
You're welcome. I'm personally excited in the work. I mean, it's good to work with data again. So, any questions on emergency department data before okay. I did just want to mention, and this came up during the psychiatry access program that DMH is funding. There are some programs through the Vermont Program for Quality in Healthcare that have been funded in part from DMH, in part from private philanthropic funding, and also in part from congressionally directed spending from our federal delegations that have really made some significant impacts in our emergency department. And I just wanted to highlight those today. So VPQHC has been offering training for trauma responsive care in emergency departments in concert with DMH. I believe they've worked with all of the emergency departments across the state. It has been very well received. The trainers include a peer component and also include a psychiatric nurse practitioner. And it's just really impressive. I would really encourage you, if the committee has time, to invite VPQHC to speak about that project, because I think it's made a huge difference. The other project that they have been working on, and I believe they are entering, or maybe just concluded year 2, is a suicide prevention quality improvement projects with emergency departments, where they've been looking through screenings for suicide prevention and using the Joint Commission standard to look at where there's opportunities for emergency departments to improve their procedures and their screening processes to prevent suicide. And I think they've had all hospitals participate both years. So we've had really good participation there as well. And then the other one, which I believe is just wrapped up, is the statewide telepsychiatry network demonstration project. And this is the one that I think is our closest equivalent of an adult telepsychiatry access program. So right now the program is focused in emergency departments, but it is built off of a program from North Carolina that I believe has expanded beyond just emergency department access. It's able to provide that consultative component. So emergency department clinicians can reach out to psychiatry for that kind of consultation support, or I believe the program also provides direct supports to patients. So if you are a person who arrives in an emergency room that does not have a psychiatrist, that you can possibly access one through this program. So with most of our hospitals being critical access, I think it's definitely a way for us to improve the availability of telepsychiatry when folks need it. And so VPQHC would have more expertise in this area, but also the North Carolina program is one that I think we should study a little bit more and might provide a lot of value to Vermont.
Great, thank you, Daisy.
Is that based off of Project Echo?
I don't believe so, but it's something called NC STEP, and I can provide links to the committee to the VPQ program page.
Yeah, those sound really great.
Mm-hmm.
Any other questions on that?
I have questions, but I'm gonna read the report because I don't want to ask you questions that might be answered in the report, and full disclosure, I have to be somewhere at 12:15, but I do appreciate what you're doing, and I look forward to reading the report.
Sounds good, and I am definitely available to answer questions after you've read or connect you with VPQ.
Thank you.
Mm-hmm.
Great. Emma, did you have any other testimony to provide? You had all your...
Mentioned that she was interested in the perinatal thing. She said she had something to say about that. Did I
I
miss
think I
something?
covered it.
I think that was the VPQHC things that she's talking about, so.
Okay.
But we can, so Emma, when Leslie had asked the question about some of these programs for adults, that was the VPQH, that was the last segment you just talked about?
Yep.
Yeah, thank you. Great. Thank you very much for all your work, Emma. We appreciate it. And this was a long morning, but I think a really, really informative one and uplifting, I will say. I think there's a lot of good work being done, understanding there's a lot of work still needs to be done. Vermonters are still struggling, but as Brian said, we've come a long way in 8 years. So thank you, everyone, and have a great day. And